गुड इवनिंग बॉस।
गुड इवनिंग, गुड इवनिंग।
एक बार बॉस स्क्रीन शेयर करके देख ले।
ठीक है, ठीक है। दिख रहा है ना? ओके।
ओके बॉस, ओके। कोई वीडियो तो नहीं बॉस?
वीडियो है, पर प्ले हो जाएगा, देखता
एक बार
हूँ।
उसको प्ले करके देख ले।
टाइम है तो प्ले करने के लिए रखा है लास्ट में।
हाँ ठीक है, कोई नहीं, एक बार देख ले इसमें प्ले सही से हो रहा है रियल टाइम में कि नहीं।
हो रहा है ना?
हाँ हो रहा है, हो रहा है, चेंज हो रहा है।
ओके, चलो।
ठीक।
तो
अनुराग सर ज्वाइन करेंगे, आपने रिमाइंड किया था उनको?
मैंने रिमाइंड किया था, पता नहीं सर उस दिन तो ऐसे ही बोला कि सरिता मैम को बताएंगे।
अच्छा। आज कुछ बोले?
आज थम्स अप डाला है बस। मैंने कॉल तो नहीं किया।
अच्छा, ठीक।
आप आरएमएल में या वहाँ पे?
केजीएमयू में हूँ मैं, सरिता मैम लोग के साथ ही हूँ।
केजीएमसी, अच्छा।
हाँ।
ओके। यूजली 6:30 शुरू हो जाता है।
हाँ कर लेते हैं बॉस, 6:30 पे ही शुरू। मतलब उनके ज्वाइन करने पे रहता है कि साथ वाले कब तक कर ले, मतलब विद इन 5 मिनट्स तो कर लेते हैं यूजली स्टार्ट।
ओके, ओके, सी। हाँ, पीडीसीसी किया था
जी बॉस, यही
आपने?
केजीएमयू से ही किया था। आपको याद नहीं होगा लेकिन हम लोग
हाँ,
आईएसएसपी कॉन जो अहमदाबाद में हुई थी ना लॉकडाउन से पहले, तो वहां पे मिले थे विनीता
हाँ,
मैम के साथ।
हाँ।
हाँ, विनीता मैम, प्रतिभा थे साथ में।
ओके, ओके, ओके।
काफी
हाँ, ओके, ओके,
पुराना
ओके,
टाइम हो गया।
ऑलमोस्ट
हाँ,
7 8 इयर्स।
2020।
7 8 इयर्स हो गए। 2020 में था, 19 में था यार।
हाँ
19 था।
19 का होगा।
या बेसिकली फ्रॉम लखनऊ ओनली।
लखनऊ।
नेटिव।
लखनऊ।
वहाँ पे कितने लोग हैं फिर? आप लोग तीन तीन चार लोग हैं क्या? पेन का?
ओवरऑल डिपार्टमेंट में तो हम लोग मतलब एक तो सरिता मैम है, मनीष सर हैं, फिर उसके बाद अभी जो जूनियर्स जो हम लोग ज्वाइन किए उसमें राजपूत है, राजपूत अभिषेक, मैं हूँ, कीर्तिका
ओके।
मैम है, और एक आयुषी है, उसने आरएमएल से किया है।
सब
कीर्तिका
लोग
मैम ने।
पेन प्रैक्टिस कर रहे हैं सब लोग?
पेन फुल फ्लेजेडली तो नहीं मिल पा रहा है, बट हाँ ये है कि जब जब पोस्टिंग वगैरह रहती है तो उसके साथ हम लोग आसपास में कर लेते हैं।
ओके, ओके। तो दोनों एनेस्थेशिया प्लस पेन चल रहा है
हाँ
ना?
एनेस्थीसिया प्लस में।
अभी शेयरिंग बंद करना है या रहने दो? स्क्रीन शेयरिंग?
उस टाइम पे ही स्टार्ट कर लीजिएगा, अभी हटा देते हैं।
ठीक है, अभी बंद कर।
एक बार रिमाइंडर डाल देता हूँ ग्रुप पे।
हाँ, ठीक है, ठीक है।
Good evening, everyone. We will be starting in a short while, just waiting for other members to join.
Good evening, Shashank.
Good evening, ma'am.
Hi, Shashank.
Good evening, ma'am. मैं वेटिंग फॉर अनुराग सर।
Okay.
अनुराग सर ज्वाइन कर ले फिर स्टार्ट करते हैं।
Hello,
Hello,
Nishad.
hello. Good evening.
सर
गुड इवनिंग।
हेलो
Good evening. Good evening.
गुड इवनिंग
Good evening.
जी मैम।
कहाँ वॉक कर रहे हो? This is on walking, and I am
Yes.
walking in VC office.
हेलो निशाद।
हाय, गुड
हाय
इवनिंग सर।
निशाद। कैसे?
बढ़िया सर।
अच्छा।
इवनिंग वॉक पर है।
हाँ, इवनिंग वॉक पे।
चलिए।
I called Anurag sir. He said he'll be joining in a while. Just waiting for him as he is the moderator.
अभिषेक।
सर।
अभिषेक वो वाला अनाउंसमेंट भी कर दो इस पे ना,
जी
जो
सर।
हमारा 24 तारीख को है कैडवरी
ओके।
स्पाइन वाला वर्कशॉप।
उसका ब्रोशर है आप लोगों के
हाँ,
पास?
हाँ मैम
अभी
है।
कर दो।
हाँ, तब तक वही कर दो ब्रोशर।
हाँ मैम, ब्रोशर है।
और ಒಂದು ಇಂಜೆಕ್ಷನ್ ಮಾಡೋ
So, so from the side of ISPC department, pain medicine unit KGMU is organizing basic and spine endoscopy workshop. So it will be a two-phase workshop. First of all, we will be organizing on the basics of endoscopy and instruments of the endoscopy and what are the views which are being taken into account and of all the types like interlaminar approach and various other approaches as well. So various we have got two guest faculties in the basic workshop. It will be on 24th May. Let me share the brochure as well. Just a second. Mm.
And in this workshop, only candidates who have done PDCC, PDF, DM are only allowed. No candidate who has done not done these courses are not allowed. Or or a candidate is a teacher in some 1 year, 2 year course. Only those will be the applicants in this course.
If you have the brochure, you can share it on screen, Abhishek.
Yeah, I'm just doing that. Mm. So is it visible?
हेलो।
Yes, it
Is
is
it visible?
visible. You can share it on full screen.
Oh, yeah.
Good evening, Anurag sir. Anurag sir has joined.
गुड इवनिंग भाई।
हाय अनुराग।
हेलो।
Good evening, sir.
आप ब्रीफ कर दो ये जो आपकी वर्कशॉप है।
हाँ जी सर। तो हम लोग ये we are going to organize this basic spine endoscopy workshop, sir, under the aegis of ISPC. Pain medicine unit of KGMU is organizing this initially basic workshop, then we will be focusing on the advanced workshop. And those candidates who are with us should ideally be either PDCC, PDF or PDF, FNB or DM students. And we only have 10 seats, and we'll like to progress with these candidates only into the advanced workshop. So our guest faculty will be Dr. Devin Singh sir and Dr. Vishnu sir. Vishnu sir is from Bangalore. He is also alumni of SGPJ, and Devin sir is also senior consultant on pain medicine. Sir has done a lot of endoscopy, work in endoscopy, and sir is also PDCC from SGPJ.
Date of this workshop?
24th May, sir. Monday.
Okay.
And this is one of its own type of this workshop, which is going to be held at KGMC. And this is a very structured workshop, and the students who are allowed in this workshops are only who have done the PDCC, PDAF, and DM, pain medicine. These or any faculty, if they want, they can come in this workshop.
I'll be sharing the brochure as well with all the people.
Thank you, Abhishek, Manish, sir, and Sarita ma'am for sharing this information. So, can we now begin with the webinar?
Yes.
Good evening, everyone. Thank you all for sparing your time for this wonderful initiative taken by Sarita ma'am and under the guidance of Ajit Kumar sir. And thank you, Manish sir, Anurag sir, for sparing their time to take this webinar forward. So, to begin with the introduction, today is a case-based approach to trigeminal neuralgia, which will be taken by Dr. Nishad PK. He is MD, AIMS, DNB, MNAMS, PDCC, FIAPM, FIPP, CIPS from World Institute of Pain, USA, and DABRM. He's a director and interventional pain physician, Cortex Spine and Pain Care in charge, Department of Pain Medicine, Aster MIMS. He's a program head in the Indian Academy of Pain Medicine Fellowship. He's president of Society for the Study of Pain, Kerala chapter. And the webinar will be moderated by Professor Anurag Agarwal sir, who needs no introduction. He's already a stalwart in the field of pain medicine. Now I request the permission of Anurag Agarwal sir to start the webinar by Dr. Nishad PK sir.
Thank you, ISPC, for having me here. So I request Dr. PK Nishad to start his presentation. I hope that it is going to be a very wonderful and informative presentation for all of our young guns of the pain medicine.
Thank you, sir. Thank you, Anurag, sir. And thank you, Sarita ma'am, for inviting me for this webinar. So I would like to discuss two cases actually of actual cases of trigeminal neuralgia and how we manage those cases. And based on that, I will discuss some technical aspects of the procedures or whatever interventions we do for these cases as well. To start with, first case is 85-year-old male patient who presented with complaints of left-sided facial pain for last 5 years duration, which was aggravated for the last 2 months. It was severe shock-like pain along the V3 distribution of the trigeminal nerve with he has pain-free intervals in between. The pain comes in attacks and in between he is pain-free and is unable to wash his face, talk or chew for last 2 weeks. Severe pain. And all neurological examination was normal except he had some trigger zones in the lower jaw. When it touches, his characteristic pain starts. And he was known case of diabetes and hypertension on medical management. So he was started on, he was seen already by neurologist and he was started on carbamazepine initially, but it was stopped due to he developed hyponatremia, so it was stopped. And later on, they started oxcarbazepine around 150 twice daily, and gabapentin was taken around 100 mg at night. But with this medication, he has tiredness and difficulty in walking, and he was not tolerating the medicine at all. So this patient was referred to us by the neurologist. Already MRI was taken, which was showing a left superior cerebral artery, which was abutting the trigeminal nerve. So by the case, it is hallmark is basically the severe paroxysmal lancinating type of pain lasting for few seconds in one or more divisions of the trigeminal. In this case, it was V3 distribution and triggered by activities like chewing, speaking, or touching the face. And all neurological examination will be almost normal, most of the cases. And commonest pathophysiology for trigeminal neuralgia will be a blood vessel, which is compressing, vascular loop compressing the trigeminal rootlets. So in this case, we are diagnosed it as trigeminal neuralgia side, and usually the management will be first drug of choice will be most of the time carbamazepine, but in most of the cases will not be able to give this medicine because of either because of the allergic reactions or because of the hyponatremia, especially in old age people. And second will be derivatives, os carbamazepine can be used, and other first-line agents will be like gabapentin, pregabalin, or baclofen. All these drugs can be used for trigeminal neuralgia. In this case, already patient was on oxcarbazepine and gabapentin, but he was not tolerating the medicines. So whenever the patient is having insufficient pain relief with the medication or there is intolerable side effects, we go ahead with the interventions. And when the patient is less than 50 years or a young patient, we'll consider first option will be microvascular decompression, especially since the patient is having a vascular loop as well. But when the patient is elderly or more than 50-55 years, then the first option will be radiofrequency ablation. In this case, our choice was trigeminal ganglion radiofrequency ablation. So just before going to the procedure, I'll just discuss the anatomy. The trigeminal ganglion is situated in the Meckel's cave, and medially we have cavernous sinus, superiorly we have temporal lobe, posteriorly having the brainstem, and anteriorly it is dividing into three branches. The superior one, the first one is the ophthalmic division, which goes to the superior orbital fissure. Second division is maxillary, which is going to the foramen rotundum, and the third division will be mandibular nerve, which is going to the foramen ovale, which is our needle entry will be through the foramen ovale. And while considering the trigeminal radiofrequency ablation, our main focus is to find out the dermatome, which area, which division of the ganglion patient is having symptoms, because we will be selectively ablating that division of the trigeminal ganglion. So we have to see V3 division, that is the third division is supplying this part like a temple as well as the lower jaw, lower lip, and lower teeth. All these are supplied by the and lateral 1/3 of anterior, 1/3 of the tongue, lateral aspect. All this area will be supplied by the V3 division. So when the patient is usually this area will be a confusing like a tumble area. When the patient is complaining pain is going to the head, sometimes we will consider as V1, but specifically we have to ask which part of the head patient is having pain. Accordingly, we have to decide. And if it is V1, usually eye, upper eyelid and forehead is the main area, and the tip of the nose and side of the nose, as well as the below eye, upper lip, and cheek is supplied by the V2 division. So depending on the symptoms, which division patient is having symptom, we will be deciding where to go for radiofrequency ablation. In this case, we have decided for V3. And patient position, we have to put a pillow under the shoulder and neck extension. That is important so that it will be easy to find out the foramen ovale, because foramen ovale is situated at the base of the skull. And we can either give a nasal prongs for supplying oxygen, or we can put a nasopharyngeal airway. Both are acceptable so that we can give oxygen while we need some sedation for this patient. And first is AP image. In AP image, we know will not be able to find out the foramen ovale, because foramen ovale is situated in the base of the skull. So we need to do a submental view. That is, we have to look from below to find out the foramen ovale, which is situated in the base of the skull. So our target is to find out this foramen ovale. For that, we first take a submental view. This is a submental view. The image intensity is taken caudally. So we can see the base of the skull is visible, but still foramen ovale is not clear. So we have to take some little bit oblique. So that is submental and oblique, so that we can visualize the foramen ovale. So this is a first step in both. If you are doing RFA or the balloon compression, the first step is same. In this case, I have used a 22 gauge RF cannula, and by end on we will put the needle, especially in the middle or in the lateral aspect of the foramen ovale. The direction, it is actually classically it is told as towards the pupil and in the lateral view in the middle of the zygoma, but in whenever you are doing under fluoroscopy, it is not a mandatory thing, but whenever you are in doubt, you can have this landmarks in mind. And we have to take a true lateral view to adjust the length of the needle. Actually, this needle was going towards like a V2 type of direction, but when we placed the needle and we stimulated, we got V3 stimulation. So we went ahead with the procedure. So this part we have to adjust most of the time for the beginners. To where to put the needle exactly is a confusing thing. So we know the trigeminal ganglion is situated in the Meckel's cave, and which is ganglion has a topographical arrangement. That means posterior and inferior part is V3, middle will be V2, and the superior medial part will be, anterior medial part will be V1. So depending on that, our needle direction also we have to adjust accordingly so that it will be very easy to get the stimulation. So I will describe this once again. So if we can plan this direction, because after putting in the lateral view, it will be difficult to redirect the needle uh, like this. This is like if we go in this direction, it will be very easy to get V1 stimulation. It will be little bit below and little bit in the middle. It will be V2, and V3 will be more of a posterior inferior direction. So to get that direction, we have to think while getting a submental view itself. For example, this foramen ovale. This is like you can see the mandibular ramus. And if the foramen ovale we are getting in the upper part of the mandibular ramus, then the needle will be going posteriorly. You can see this needle will be going posteriorly. That is for V3. For V3 division RFA, it is better you keep your foramen ovale in the upper part. And sorry. So this thing has changed a little bit. Sorry, I'll just adjust that picture. So if you want to go for V2, it is better you keep your foramen ovale in the middle. Okay, little bit below this one. The direction will be accordingly. All this has changed actually, sorry. It will be like this. And if you want to get V1, you have to take the your needle, foramen ovale, you have to okay, so in this picture, I will describe once again. If you want to go for V3 RFA, it is better you keep your foramen ovale in the upper part of the mandibular ramus towards the mandible. And if you want to get a V2, you have to keep in the middle, and for V1, you keep in the lower part. So that means for a V3 RFA, you need a little less submental submental obliquity of the C-arm. And for V1, we need more. So that your lateral needle placement will be accordingly this one. The first one is here, that is posterior and inferior. Second one will be here, that is for V2, and the third one will be for V1. So it will be very easy to get the stimulation when you are finally getting the stimulus. It will be easier, especially for the beginners. We should consider this while doing the procedure RFA. And after getting that position, you have to do sensory and motor testing at 50 hertz sensory. Usually we'll get stimulation between 0.2 to 0.3 or less than 0.5 is required for paresthesia or pain along the required distribution. After that, we can do a motor testing at 2 hertz, and we will be getting mandibular nerve contraction, especially we are doing B3, and it should be more than the volt, whatever we are getting on for sensory, it should be more than that. And usually I do 2 lesions. In this case, we did one lesion at 70 degree for 90 seconds, and second lesion 75 degree for 90 seconds. So usually the complications of radio frequency ablation, the numbness will be a side effect of the procedure. That is not a complication. We are expecting that. And dysesthesia, like discomfort, is around 5 to 15 to 25% patient can have dysesthesia. And anesthesia dolorosa is a very rare complication, but it could be there. Masseter muscle weakness can happen, especially when we are doing V3 RFA. And the other things, like if you are doing a radio frequency ablation for V1, the possibility of corneal anesthesia and keratitis is there. All other complications are very rare. So, shall I go ahead with second case, sir? Anurag, sir?
Yes, you can proceed.
Yes, you can go proceed.
So the case 2 is like a 76-year-old lady who complains of pain along the left side of the face for last 6 months duration. Pain is like severe pain along all the 3 divisions, and intermittent shock-like pain along with for last 1 month she is having continuous pain as well. In between also she is having a background type of pain. She has no comorbidities. MRI was not showing any vascular loop, only age-related ischemic changes was there. So this patient was initially managed with she was allergic to carbamazepine and oxcarbamazepine, which was started earlier. So she was on gabapentin 300 mg twice daily, as well as lacosamide 100 mg twice daily, with no relief in pain. So she was referred for procedure. Actually, in this case, since she is having all the 3 divisions of trigeminal distribution, she was having pain. So we planned percutaneous balloon compression. Usually, this procedure is done under general anesthesia. I usually do under IGEL. I'll do IGEL and spontaneous ventilation. I do this procedure. It can be done under endotracheal intubation also. The equipment, the kit I use is like a custom-made kit. This was designed by Rastogi sir. So, which include a 22 gauge 10 centimeter needle, one small dilator, and 16 gauge dilator. Sorry, this was a guide wire, and 16 gauge dilator and 14 gauge cannula. These things, and along with the 4 French Fogarty catheter we use. So basically, percutaneous balloon compression consists of 2 main steps. The first one will be correct needle insertion at the foramen ovale, and second will be to get the correct balloon shape in the Meckel's cave. So the first initial step I already described. These are same. Like you have to take a submental view, find out the foramen ovale, and from this is the patient's this patient's picture. So we have to take, usually I prefer to take this foramen ovale in the lower part of the ramus. As I told, like a V1 distribution. When we consider radio frequency ablation, we take for V1, you'll be taking the foramen ovale here. So depending on this position, I prefer to go for balloon compression. So first thing will be identifying this foramen ovale, and then we'll put a 22 gauge needle end on in the middle of the foramen ovale, and we take a true lateral view. True lateral view is a must because we want to know the depth exactly, as well as the shape of the balloon will be depending on that. So we will place the the needle should enter into the Meckel's cave, and after that, over that 22 gauge, we will be putting the guide wire. So we have to keep the guide wire in the Meckel's cave, and over the guide wire, we are putting the 16 gauge dilator. That before putting the dilator, we have to put a small skin nick by a 11 number blade. Then this 16 gauge dilator will be blunt cannula. So we have to, by twisting movements, we have to dilate the track. So this dilator should be inserted into the Meckel's cave. This is, it has to go till the clivus, because otherwise, if you keep it till here, it will be very difficult to insert the Fogarty, because that will not go inside. So you have to dilate it here also. Then over the dilator, we put the 14 gauge cannula. So that 14 gauge cannula should not enter the inside the foramen ovale. It should be snugly fitting the entrance of the foramen ovale. After fitting this one, we can remove the dilator and we can put the Fogarty, 4 French Fogarty catheter. That Fogarty catheter has to reach the clival line we have to reach. At this point, we can do under continuous fluoroscopy, we can inflate the balloon, and the balloon shape should be like a pear shape. That is very much important, because this proximal part has to enter the porous trigeminal. Then only the effective compression of the trigeminal ganglion will happen at the Meckel's cave. So I have a small video, but this almost we have discussed it. So if you want, so that is almost same things. We are putting the 22 gauge needle first in the middle of the foramen ovale. Then after that, we will take a lateral view. In the true lateral view, we will be adjusting. We are putting the guide wire. We will remove the needle stillet and put the small guide wire through that. So while inserting this guide wire, we should be very careful. One problem is it will go inside, unknowingly it will go more inside. So now the guide wire is there. Over the guide, now we have to remove the 22 gauge needle and put a small nick there. Then we'll remove this 22 gauge needle. This should, this at this point you should be very careful while dilating the track. There is very high chance that this inner guide wire will move inside, move more. So you should be very careful while dilating. One should stabilize this guide wire. It should not go further inside while dilating the track. So care should be taken at this point. And after that, this is a dilator in place, and over this dilator, we will be putting the cannula. Once the dilator is in space, it is very easy. We can railroad the cannula very easily. So at this point, we can take an AP view as well, so that the direction of the needle we can confirm whether it is directing towards medially. And after your cannula is in place, you can take the dilator. Usually, venous bleeding is common. Don't worry about it. We can put the Fogarty at that time. And the Fogarty catheter is inserted. The Fogarty should be there till the clivus line. After that, in continuous fluoro, we have to inject dye. Dye volume will be usually around 0.6 to 0.8 ml volume might be required for a good pear-shaped balloon. Then we have to maintain that pressure. Usually, I do around 3 minutes to 4 minutes compression. So this is a continuous fluoro. We can see the while inflating, the balloon has to inflate and it has to go to the trigeminous porous trigeminal. So the importance is while inflating the balloon, it is filling this Meckel's cave and the proximal part will be going into the porous trigeminal through which the trigeminal rootlets are coming, and it will not be going down. This area will not be there. So that is the shape of the balloon is by this only. So this is a that is why we are getting a pear shape. There are different type of pear shape is there. So all these are acceptable, and the if the typical pear shape you are not getting, you should be checking whether your position might be either too inside or too outside. If the balloon is here, somewhere around here, you will get a cucumber shape of balloon, and if it is like more, you will get a dumbbell shape. It will be like a dumbbell shape. It is more half inside and half outside, and if it is more inside, you will get a inverted pear shape. That will be the major part will be inside the middle crania fossa, and or you will get a balloon type of filling. All these are like a two inside. You have to withdraw the Fogarty if you are getting this sort of. So all these shape can be uh, present if your needle is in the Meckel's cave and sorry, in the foramen ovale, and you are placing the Fogarty. But the depth is variable. Like each picture, the depth is variable. You have to adjust the depth. So you can see the same picture. This cucumber shape is when the Fogarty is inside, just a little inside, but not reach the Meckel's cave, and it is in the middle. And this is a typical shape we get. This is a inverted pear shape. That means that your catheter is Fogarty is more inside. This is also good shape, pear shape. All these are acceptable. This is also acceptable. This is like a dumbbell shape. It is little bit more inside. You have to withdraw the catheter. This is looks like a good shape, but this is actually inverted pear and it is more inside. You have to withdraw this is a good shape. You can retain it. This is also dumbbell shape. It is more inside. And these two are balloon shape. That is shows that your catheter Fogarty is more inside into the middle cranial fossa. All these things we have to adjust the position. The major complications are like facial hyposthesia as RFA. This is also acceptable. It is a acceptable side effect, and compared to RFA, it is a little bit less in balloon compression. That is why if there is a V1 distribution pain, we usually consider trigeminal balloon compression. Bradycardia and hypotension is an expected complication, especially while doing inflating the balloon. So we should be prepared for managing a refractory bradycardia that can happen. And masseter weakness is common, and some jaw deviation also will be there post procedure. Usually it will be for 1 to 1.5 months it will be okay. And injury to the cranial nerves like third, fourth and sixth cranial nerve, especially the abduction. Sometimes if you inflate more or your catheter is little bit inside, there is a chance of lateral rectus palsy. Patient can have a double vision. Even if that happens, you have to reassure the patient that will be normal within 1 to 1.5 months, that will be reversed. And meningitis, hemorrhage, and all is very rare. Only if it develops, it is very difficult to manage, but it is very rare. And as we know, the different percutaneous options are available for trigeminal neuralgia. Glycerol isolysis is used only if RFA or other options are not available, and it recurrence rate is high. Radiofrequency ablation give a good initial pain relief, and the recurrence is around 1.5 to 2 years average. You will get the pain relief, and balloon compression also average is almost 2 to 3 years. Uh, Microvascular decompression is the best treatment. It is just giving maximum duration of pain relief. Thank you.
Thank you, Dr. Nishad. Very nice presentation.
Thank you, ma'am.
One question I want to ask on behalf of young pain physicians, what is your experience under this procedure?
Ma'am?
What is your experience between two procedures, RF and balloon compression? What advice you will give to the young physicians according to your experience?
For the always for single division neuralgia, except V1, I usually prefer radiofrequency ablation. V1, V2, V3, all division, I usually prefer radio frequency ablation. If the V1 is involved or multiple divisions are there, or if the patient is, I feel sometimes what happens is even if it is V2 and V3, patient is not cooperative. Sometimes it happens. So it will be very difficult to get the exact simulation, whether V2 is getting or not. In such cases also, I prefer to go for balloon compression, because balloon compression is done under GA. There is no stimulation is required. All the divisions are compressed. So if the patient is not cooperative, then also I will prefer balloon compression. Otherwise, better is like a single division is better always, radio frequency ablation, because we are ablating only that single division.
Okay, thank you. According to your experience, what type of complication you have faced a lot in RF as well as in balloon?
RFA usually mainly the dysesthesia is a problem. Usually, even if I tell the patient that you will have numbness, some sort of difficulties will be there, but still the patient will come and complains regularly. I have numbness is not gone by when it will go. All these things will be there. So
Many
numbness,
times, many times
most
patient
of the
comes
time.
with the numbness.
Usually patient they'll forget their pain actually. After that they will be coming and telling you to remove this numbness, how to do for this numbness and all. And second thing is paresthesia, like deafferentation pain. Not classical deafferentation pain, but some patients complaints are around burning sensation, especially that area. They don't have that classical neuralgic pain, but they have some sort of pain. That complaints will be there. And a few patients complaints of ear block. Ear block means they have some issues in the ear. That is basically because of the tensor vale palatini muscles are there, which are supplied by mandibular nerve. So when we are ablating or we are doing balloon compression, that muscle become weak. So that will cause eustachian tube dysfunction. And so all these patient will have some ear block. They'll be telling ear block or some discomfort in the ear. So that is also an expected complication. So all this actually what we can do is there is no treatment for all this. We have to wait and watch. We have to reassure the patient, because that will gradually improve when the motor this thing masseter weakness improves. Similarly, that other muscle also will get improved, and later on it will be okay. But initial 1 to 2 months we have to reassure the patient. So during that time, patient will be complaining of. And for regarding the balloon compression, common thing is again this numbness. And usually after the balloon compression, I prefer to give two things. I tell them patient to use a specs for few months. If they are already using, they ask them to wear it regularly, because some sort of corneal numbness is there even after the balloon compression. It's not like there is no corneal numbness. Corneal numbness will be there. So I tell them to wear specs, as well as I usually give some teardrops, artificial teardrops, refresh eye drops, so that even if some dust goes to the eye, it will be cleared. So these two things will be given regularly after balloon compression for all patients, at least for 2 to 3 months. And after that, I will check if now this thing sensation is okay, I will stop it. Otherwise, usually give for 2 to 3 months. And the complication which I had attend is like two patients developed this thing, abducen nerve palsy, and both patients actually recovered after around 6 weeks. They had a diplopia actually. It will be very difficult to manage. The diplopia will be severe. Diplopia will be there sometimes. So one patient required eye patching. They had to close that eye, but after 1 to 1.5 months, both the patients recovered completely. And the bleeding is common. Like at the time of the procedure, bleeding is very common, especially most of the time it is like a venous bleeding. So we have to control the BP while doing anesthesia, general anesthesia we are doing. So better to keep a BP on the lower side, one thing. Second thing, whenever bleeding is there, immediately put the Fogarty and compress it. So that most of the time venous blood will stop. So I usually, if the bleeding is there, I will keep the catheter, withdraw the Fogarty little bit towards the entrance of the foramen and keep it inflated for some time and then take it out. And you have to give a good compression. Most of the time, that patient will develop a cheek hematoma after the procedure. So we have to reassure them. You have to tell them in advance that you will have some hematoma. You have to put ice pack. It will be there for around 1 to 2 weeks. Then it will be okay.
Okay, okay. Thank you, Dr. Nishad, for very good explanation. There are many senior pain physicians on the forum. Dr. Shivani, you want to add something? Want to give your any input regarding Dr. Sushil Jaiswal?
Hello, Dr. Nishad, very good presentation. I want to know how to get the time 3 to 4 minutes.
How?
Time.
You inflate the balloon for 3 to 4 minutes. I
Yeah.
usually inflate for 90 seconds.
Yeah, sir. I like the textbook says 90 seconds, but I what I feel is if you inflate for at least 3 minutes, if you are getting a typical pear shape, I usually keep it inflated for 3 minutes and then stop. Okay. So if you are
Sometimes,
not getting, sometimes what happens is not typical sphere, you are getting okay type of this, then we'll first keep it for 1 minute, then we'll adjust a little bit, either inside or outside. Then again we'll inflate and see, and 1 minute more like that. So
I
we'll,
got your point. You use in a 2 to 3 times. Means one times you use 90 seconds, then readjust your balloon and then increase for 9 seconds. Okay.
yeah, we are getting a typical peer, it is continuously you can give for 3 minutes and stop it, finish it. Yeah.
3 minutes at a time or in a block of a 90 or
No,
120,
no. I usually give it continuously 3 minutes, sir. If your balloon is in pear shape is typical, continuously inflate for 3 minutes and remove it. That's it.
Okay.
What was the incidence of abducens nerve palsy in your cases?
It is like maybe out of 100, 1 or 2 cases.
Okay. Because 3 to 4 minutes may cause the nerve palsy. It's written in the literature.
Yeah, yeah. But you do this thing for all patients. Only 2 cases I have, but that balloon was not a ideal pear shape. That was the problem, basically.
Okay.
That is not an ideal shape. And both the 2 cases happened in the initial time. That is my first 10 cases, within my first 10 cases.
Okay.
Any other question? There is a question in the chat box, Dr. Shashank.
Chat box.
It's mentioned, sir, in first case, if patient developed hyponatremia on carbamazepine, then
Yeah.
why shifted on oxcarbazepine as it causes more hyponatremia by Dr. Sohit.
Actually, at that time itself, I explained that the patient is already managed by a neurologist and they only was taking that medication. And the patient, when I referred to me, the patient was already on that medication. So I didn't adjust any medication because already patient is not tolerating any of these medicines. So I directly went ahead with the intervention in this patient. Actually, it is if the patient develop hyponatremia, usually we don't give the same group of medicines. So usually shift to either gabapentinoids or baclofen usually.
Any other inputs from Dr. Manish? You want to say something?
Anyone can share their insights, the problem they face, how they overcome them, how they troubleshoot, or discuss about any case particular to this trigeminal neuralgia, their experience, not just question.
One more thing about the guide wire. Putting a guide wire is very thin and it's most of the time you go inside. So in place of using is a 22 gauge, you can use initially 20 gauge and then you use as a 22 gauge long needle as a guide wire. Then the misplacement of the guide wire is less than the earlier one.
When we are using 22 gauge needle as a guide wire, we have to cut the needle hub.
And
So
cut you usually you
that
cut only
usually,
one needle and then use autoclave every time. You use
yeah, yeah,
only
yeah,
22 gauge. Then the misplacement of the guide wire is the less. Then the
yeah,
you
yeah.
use the thin guide wire.
Yes, that we can do. If the wire cutter is there, we can use
You cut a
only,
single time and then every time you autoclave there.
yeah, yeah. So we can,
Otherwise, cutting is the one more problem. At type of cutting, sometimes the bend. At cutting sharp cutting, they bend and then the rear load is a problem. So cut one time and nice one, and then you put always use as a autoclave.
yeah, yeah, we can use that also, sir.
Because you use the Rastogi kit, which is generated by me, is originated by me.
Yeah.
Yeah, 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 I know, sir.
There are two more questions. Any experience of combining pulse with thermal by Swapnil sir? And literature
Yes,
mentions better
I,
result.
yes, I always use, but never told anybody. I always use the pulse because I use the needle for the first needle for the guiding. So I always use to pulse RF. There is no any harm to use pulse RF.
We are also using pulsed RF. Yeah, RF. Balloon compression is
Combined with
very
the balloon.
less.
Yes. No, I always use the pulse RF with the balloon compression.
But pulse RF results are very for short time.
No, man, it's
Only
not for result. It's for a combined effect of with the balloon. Because I always used to balloon. So I for first needle I always put RF needle. So I use pulse RF, but because both are the change for sensory motor and for pulse RF.
Dr. Priyanka is asking what has been the worst complication experienced by you ever during or after the procedure?
It is like once patient developed a cardiac arrest. That was the worst complication. That is because
Yeah.
not because
Is it
of the
recover or
procedure.
not?
I recovered
Yes,
immediately.
yes.
Because of the sedation which we provided while doing RFA, patient will have pain, will give some proper fall. So patient went into bradycardia and so immediately recovered, but it was one complication. So that can always
it
you
is
should be
because
prepared
of
while
trigeminal
giving.
reflex also. No?
Yes.
That can be that is by basically while doing the RFA we give some sedation and patient airway is not protected, so we'll be giving fentanyl as well as little bit propofol also we give while doing the RFA. Or if you are not getting with this, especially where there is CSF leak, will not give much local anesthetic. At this point, we can have these things. And another question was there in the chat box, it is CSF leak. If CSF leak comes, there is no issues. We can go ahead with RFA. There is no only thing is you should be careful while giving local anesthetic. So it is not a contraindication for RFA. Any other thing?
There are other questions, Sashank.
So,
1 minute.
I don't have. I usually go for thermal RFA. I don't have a experience with the other this thing pulsed RFA or radio trigeminal actually.
And, some patient developed continuous burning pain after the procedure in 3 to 6 months. How to treat that pain?
So this patients has to be treated as deafferentation pain. Actually, I prefer to give gabapentinoids and tricyclic antidepressants. Usually, we don't give tricyclic antidepressants for trigeminal neuralgia pain, but post RFA pain, it is well managed with tricyclic and gabapentinoid combination. either pregabalin or gabapentin, along with you can give amitriptyline or nortriptyline. So usually that will be controlled with that. I'll give for a few months and then stop it.
What is your protocol in post-op for carbamazepine? Do you stop immediately or
No,
taper
usually
it?
for next 2 weeks after the procedure, the same medication, whatever they are taking pre-operatively, pre-procedure, I will continue that medicine for 2 weeks. And I will review the patient after 2 weeks, reassess the relief and all. After that, I will gradually wean off the medicines. Not immediately, I will not stop. If the patient is on 2 or 3 medicines, gradually one by one, I will cut the medicines and gradually wean off. If only one medicine is there, usually decreases the dose and stop it.
This is very important. I know one patient that was on 800 carbamazepine, Tegretol, and we stopped and she went into withdrawal symptoms.
Yeah,
So we
usually
should taper slowly.
they'll have a problem with this thing. Lot of issues will be there if you stop immediately.
Huh.
They'll not have sleep also.
That was in initial phase. Then we realized we should taper slowly.
There is one other.
Steroid. There is a question of steroid actually. I usually give after RFA. Usually I give dexamethasone around maybe 0.5 ml of dexamethasone. I'll give then remove the before removing the needle cannula.
One question is for Sarita ma'am. What is your experience with high voltage PRF? Can you briefly tell about the voltage and time you said?
Yeah. There is a question, Dr. Nishad. What is your experience with high voltage PRF? Can you briefly tell about the voltage and time?
No, I saw that. I saw that. I am not using. That is why I am told, ma'am.
We did a thesis on PRF and CRF, but our results were very weak results were there. For 2 to 3 weeks or month only, patient had pain relief, and again we have to do CRF in these patients. So out of about 25 patients, only 10 has 6 months pain relief.
Sir, I have a question. First of all, very nice presentation, Dr. Abhishek here. Sir, I had a patient of 75-year-old male, and we were able to visualize the foramen ovale, but it was ossified. So in that case, we tried to walk off to enter till the foramen, but then there was trigeminal cardiac reflex, so we had to abandon the procedure. So if we encounter such cases, as we routinely use this procedure in old age patients, and if the foramen ovale is ossified, the others can also, seniors can give the input. What can we do, sir?
Medical management is only that.
Allah, if you are just near the foramen ovale also, if you are only V3 division symptoms are there, we can do there. Some radio frequency ablation you can with a low temperature, you can do at that level, entrance itself, if you are getting stimulation. Not,
Actually, sir, we tried to walk off the foramen, but we were not able to enter the needle because we thought that it was ossified. So when we went somehow after walking, so there was bradycardia to the patient.
that
So
means you
anyhow,
are
we
near the
abandoned the
nerve, you
procedure.
are near the trigeminal ganglion, you have to manage it like you give atropine and again reintroduce the
Again,
needle.
okay.
That is actually, that means they are near the nerve or the ganglion. Okay. So if the
Yes,
patient
sir.
is getting trigeminal cardiac reflex, so you give atropine, then again go ahead with the procedure. If you are getting bradycardia, we do that only. Even with the balloon or the other one, while putting, if the patient is developing bradycardia, we give atropine, remove the needle, give a bradycardia, treat bradycardia, and then when the heart rate is okay, then again go ahead with the procedure.
Thank you, sir.
There is another question from Dr. Neeraj Dahiya. Can we do TGN block with fine needle in Meckel's cave, meningomyelocele in right Meckel's communication with CSF? Or shall we go for the peripheral blocks for V1, V2, V3?
Meningomyelocele, I think it is better if there is a anatomical issue in the Meckel's cave, it is better don't go there because that might invite complications. You can go with the peripheral block, especially if the patient is having V2 or V1, we can go ahead with the infraorbital or supraorbital pulsed RFA plus or minus neurolysis. I usually do neurolysis, peripheral neurolysis, especially in old age or poor patients, those who are not affording the RFA. You can go with phenol. If you do phenol neurolysis of the infraorbital nerve or supraorbital nerve, that will usually give a relief of around 5 to 6 months easily. So that can be tried in such patients. V3 will be little bit difficult. We can go with the pulsed RFA under ultrasound guidance, like a peripheral nerve pulsed RFA.
There is another question from the Dr. Samprita. Any predictors for the recurrence of pain after RFA? Some patients do come back with recurrence of pain within 2 to 3 months after procedure.
Predictors, one thing is if the needle is not nearby, you are getting a stimulation of the pain around more than 0.5 volt. That means your needle is little bit away. In such cases, the recurrence rate will be very high. If it is better, you get it within 0.3, like you should be in the ganglion. So then the duration will be more. So you have to try for the stimulation within 0.3. If you are getting it more than 0.5, you readjust the needle and try to get it. Another thing is recently I started using 20 gauge needles actually. So 20 gauge 5 needle I have started using. So that is also giving more prolonged relief actually, maybe because of the larger lesion. So that also can be tried actually. Bigger needles and like you are getting stimulus within 0.3. All these things will give long-term results. And another problem is usually patients duration of the pain. Like if the patient is having long duration trigeminal neuralgia along with a continuous background pain, such patients also will have poor results in for RFA. That is not the duration, the results itself will be like maybe not as good compared to the classical trigeminal neuralgia.
Yes, there is another question from Dr. Karthik. If you have differentiation pain after procedure, then what is the treatment? You can use sphenopalatine ganglion block, Botox. Yeah, what is your experience? And
Till
patients
now,
comes with an anesthesia,
till
sir.
till now, by God's grace, we could have managed with medical management actually. But that much severe anesthesia also I couldn't. Till now, I didn't get it. Only mild type of pains, burning pain, all these things we got. That was managed with the medical management. And actually, we can plan these sympathetic blocks. Like SPG is an option if the patient is having severe anesthesia dolorosa. That is an option.
Dr. Abhishek Raj is asking that in patients with TN, when should we consider peripheral nerve block?
That is like when the patient is coming with a severe neuralgic episode in your OPD, you can give immediately, you can consider a peripheral nerve block so that patient will be comfortable. If the patient is having severe pain and not manageable with the medication, then any medication you start, it will take a few days. So if the patient is unable to open the mouth, unable to talk, unable to eat, then at this that point an RFA, immediate RFA is not will not be an option. So what we do is give a peripheral nerve block with local anesthetic and steroid. That will give immediate pain relief to the patient. Patient compliance also will be good after that. Even if you tell this thing, any intervention, they will be accepting that intervention. And second thing, they will get a immediate pain relief. And if the patient is poor and only infraorbital neuralgia or only supraorbital neuralgia type of things, then you can consider with a neurolysis also, so that patient will get a long-term pain relief also. That when they are coming back with the pain, we can consider RFA. That also we usually do in practice.
Okay.
Phenol usually we use around 0.5 ml only. 0.5 ultrasound guided only we do all this peripheral neurolysis, and 0.5 ml phenol and 0.5 ml local anesthetic usually.
Yeah. So I think Dr. Shubha Lakshmi has got their answer. Phenol 0.5 ml of phenol can be used in this procedure. So one question I want to ask Dr. Nishad, because you have done approximately 100 or more than 100 patients of the TGN. So what important investigations to be done in your experience for the new pain physicians?
Like a preoperative investigation,
Yeah,
ma'am.
yeah, preoperative or the when we are preparing the patient for the procedure, what important MRI or what important
All
investigation scan
interventions,
is
if
important?
if I am going for an intervention, trigeminal intervention, always MRI I will take. MRI is a must because we should know the anatomy, the any issues are there or any other problems are there. It can be due to other reasons also. It may not be a classical trigeminal neuralgia. That also is possible. So we have to rule out secondary causes of trigeminal neuralgia as well. So always I go for an MRI with the FISTA sequences before considering an intervention. Second thing is all basic blood investigation, count and coagulation parameters, PTNR, and ECG. I usually, as a PSC checkup, I do, patient will be either sedation or GA. We will be doing the procedure. So all patient will be done a PSC checkup. If it is done in my clinic, I do myself. Or if we are doing under hospital, we'll take a anesthesia PSC checkup so that an ECG, and if the patient is old age above 75 and all, any other comorbidity CAD, we will go for an echo also as well to before going for a procedure.
Okay. And what are the important contraindications when we have not touched the patient for any intervention for this cesarean care?
Yes,
अपार्ट
sir.
फ्रॉम जैसे हम एनेस्थीसिया हम पढ़ते हैं एब्सोल्यूट और इस आपके एक्सपीरियंस के अनुसार क्या होना चाहिए, कब हमें पेशेंट को टच नहीं करना है?
Contraindication as absolute contraindication is coagulopathy only. Like already patient is on some anticoagulants and we can't stop it. Like a patient had underwent a PTCA for last 6 months or so, we cannot stop dual antiplatelets. Such cases will not go ahead with the procedure. Only peripheral nerve that in that cases also we do peripheral nerve blocks with the 26 gauge needle, but will not go with the RFA or this thing. Otherwise, I don't think there is an absolute contraindication. If
Yeah. Okay. There are, I think time is over. One more question. Dr. Karthik has asked how soon patient would expect from pain relief after PVC or RFA procedure?
you usually immediate post procedure patient will have most of the patient, but very rarely some patients around 15% of patients will have a pain, persisting pain sometimes post procedure. So don't worry about that. So most of that patients will be okay within around 10 days. So I usually tell them your pain, some sort of difficulties will be there for 1 week. So I usually continue whatever medication patient is taking, I continue for 2 weeks. That is why I told all patients I continue the same medication for 2 weeks. Review after 2 weeks. I tell them 1 week, don't worry about pains. You will usually the one complaints will be headache. Post RFA or balloon, patient will have headache immediate post procedure for 1 or 2 days. That is acceptable. So we'll tell them that it will be okay. I'll give analgesic for 2 3 days also. Post procedure I usually give 2 3 days analgesic and one course of antibiotic because we are entering the CSF. So we usually give 3 days of antibiotic as well. So we'll tell the patient that he'll have pain, but 90% of the patient will have immediate post procedure pain relief. Only
Okay.
they have the pain, but it is not the classical shooting type of pain. They'll have some procedural pain and headache. That is common.
Okay. One more question. Dr. Abhishek Raj is asking that if patient come back with similar pain after 1 to 2 years post RFA, should we go for the repeat RFA or PVC?
Repeat RFA. If the patient is
Repeat RFA.
getting relief, we are expecting 2 years only. I tell them average is 2 years. So if they are coming back after 2 years, we will repeat. And there are some patients they corrected they see the date and they'll come back on that date. Even if they don't have pain, they'll tell almost time हो गया अभी करना है नहीं करना है. So that is we can repeat it, no issues with the RFA.
And after 1 to 2 years, so we can repeat easily, no problem. There should not be any problem.
And sometimes once what happens is one after doing RFA, patient is like a V2 and V3 RFA divisions was there. Patient while stimulating, but they told V2 we have V2 stimulation आ गया, and patient was not tolerating the procedural pain also. So we did RFA and post procedure patient was persisting pain actually. V3 was okay, V2 pain was there. So inside that patient, when the patient came back with the pain, I went for balloon compression actually. So under GA, it was comfortable and patient is very much comfortable post procedure. So if the patient is not cooperative, we can decide, we can change to balloon compression actually.
Yeah. So there is one last question from Dr. Nikita. How is your experience with RFA in case of vascular loop compressions? Vascular loop compressions of TN?
Ma'am, that I told actually, if the patient is above 60 years, even if the vascular loop is there, we usually go for RFA only.
RFA.
Will not consider this thing. MVD only less than 50 years, we usually tell them directly go for MVD. Only if they are not accepting, then only we'll do any intervention in such
And
patients.
if pain is not relieved, this RFA
With the
we can
medical management, then
medication.
we'll go for RFA or this thing balloon compression. Even if the patient is having 25 years and the patient is telling, I don't want surgery and they have severe pain, then we can consider. And another thing is if female patient, they want to conceive and they don't want to go to surgery, then also we'll go for RFA or the balloon compression so that they will get a relief for that period.
Okay. Anyone other want to ask any question? Dr. Vishnu, you want to add something?
Ma'am, good evening, ma'am. Good evening. No, ma'am.
Hi,
Sir,
Vishnu.
thank you for wonderful discussion, sir. Thanks a lot, sir.
Very
We are
nice
learning a lot from
presented,
you, sir.
presented by Dr. Nishad, and very wonderful explanation which you have given to our young pain physicians. Thank you so much for coming and delivering your lecture. Dr. Shashank.
Thank you, ma'am.
Ma'am, one
Thank
more
you
question.
so much.
Last question, sir. Sir, how to prevent needle entry into the mouth? Any technical tips, sir?
Usually, textbook says to put one finger inside, but I usually don't do that. If you are, usually I prefer to take that foramen, I show that picture, foramen ovale near towards the mandible, right? So if you take the foramen ovale near to the mandible and we are going end on, then the chance of entering the mouth is very rare. Only that happens in the cases of edentulous patient. We should be very careful in cases of edentulous patient while putting the needles. There is a chance that it will enter the mouth. Otherwise, it is very rare actually. Usually, textbook says you can put a gloved finger inside till it enters the foramen ovale. I don't do that actually.
Okay, thank you, sir.
Thank you so much, Nishad boss, for taking such a wonderful webinar and answering each and everyone's query so beautifully that everyone seems to be satisfied and over satisfied. It was a very nice lecture, and thank you, Sarita ma'am, for taking this initiative for budding pain physician and the experienced one to share their insights about various procedures and how to manage a case-based approach. So thank you everyone for joining this webinar. Next, we will be meeting on 29th May on a lecture by Dr. Anuj Jain on low back ache. So thank you,
Okay,
everyone.
thank
Thank
you.
you so
Thank
much.
you. Good
Thank
night.
you, everyone. Thank you.
Good night, ma'am.
Good night.
Thank you, sir.